Welcome to Yashoda Hospitals for the Nursing Education and Training webinar. Today we are here with the most interesting topic on every Thursday, 3 p.m. So here we have got our expert panelist for the day, Dr. Prashant Reddy sir. So who is our HOD for anesthesiologist and the pain physician. We welcome you, sir, onto the panel. And also we have got a person who is enthusiastic with the 10 more years of experience, and she is here for talking about the topic where she will elaborate a lot about her experience also putting on into this. She is none other than Ms. Chandani Mulikantla. So she is the AGM nursing at Somajiguda, Yashoda Hospitals. So we are here for the topic. Let us discuss more about it, more elaboratively with her words. Over to you, Chandani. Thank you, Pratisha. Thank you for giving me this opportunity to be part of this valuable webinar. Today's why we have chosen this topic. So just try to understand avoiding surgical disasters. It's like we have been read so many times. We have been watched in so many times in the newses, and many we have heard about the surgical disaster in our past experience in previous hospitals or somewhere. So coming to this topic, like we are dealing with human beings, so we should understand to prevent the surgical disasters. So let's talk about few thumb rules which we have put together. So let's discuss about today's objectives like phases of perioperative care, as well as some vital parameters in preoperative checks. Connected towards intraoperative care, it is very, very important. IPSG goal number 4, surgical safety checklist, as well as after surgery, we'll be dealing post-operative care management, how effectively. So this all experience, we have to give better experience to the patient so that enlightened experience patient can be discharged very safely. So what is perioperative nursing? So we have been read in our previous, curriculum also. Perioperative is nothing but all comprises of parameters like preoperative, intraoperative, and postoperative phase. So let's understand preoperative and intraoperative, postoperative phase. So preoperative phase. So the actually preoperative phase begins the surgery, the decision of surgery, of intervention of surgery, till the patient is being shifted to the OT, that consists of preoperative phase, which we have to be understand. So many factors need to be taken in this place. So the first of all, would like to emphasize on nursing assessment as patient is being admitted in ward setup or critical care setup. So it is very important the nurse, assigned nurse need to be assessed parameters of, to find out what are the comorbidity factors, as well as she has to do the systematic assessment, head-to-toe assessment. We can rule out so many complications, as well as nutritional status. Like, we can pick up a lot of complications. We have to find out allergic factors, what are the allergy medicines patient has encountered previously, as well as patient is on pre-medications. We can collect the history of on pre-medication. We can find out baseline data about the preoperative assessment. As we all know, any patient is being wheeled to a surgery. So we have to do the baseline investigations as per the doctor's order. So try and understand investigations we'll be sending, and we have to find out the abnormal values, need to be informed concerned doctor. And coming to the nursing checklist, preoperative checklist. So it is very important. This all comprises of checklist before shifting a patient into a OT. As a nurse, we have to look after one second. Slide change is not happening. Yeah. Preoperative checks. So as a nurse, before shifting a patient into a OT, we have to ensure these all checks need to be done. So as IPSG goal number 1, identify patients correctly. This is very important. So many times what happens, we heard many times wrong patient being shifted into a OT, wrong patient is being operated. So these all disasters can be prevented with proper checks. So I would like to emphasize on identify patients correctly with 2 identifiers. So as per your hospital policy, as well as the important thing is cite correctly. So site marking is very important. As a surgeon, site marking will be done by the surgeon or surgical team member. So site marking can be prevented. We heard many times right side being actually supposed to be operated, but left side being operated. So this this sentinel events can be prevented with this proper check. And second thing is informed consent. This is very, very important. Informed consents, we all are aware, informed consents are very important factor before any patient, before doing any procedures, before doing any surgery, we have been taken, like we have been taking an informed consent. This informed consent need to be taken by the surgeons. But as a nurses, we have to ensure consent need to be completed in an appropriate manner. Okay. The next is identification of allergies. As we all know, identification of allergies, like, maybe patient is allergic to previous anesthetic, medicine, or patient is allergic to some medications. This all allergy history can be find out priorly, so that this will be helpful for the anesthetist to go for smooth functioning of anesthesia. Yeah, preoperative, as continuation of previous slide. So nurse has done the workup preoperatively. The next thing is the handover time. The assigned staff will be coming to our pre-op area, as well as her responsibility. She has to be complete her documentation with valid lab reports, as well as radiological films need to be handed over. And whatever patient is on, started on the drips, medications need to be continued further. And any other devices, patient is on some devices, like say patient is on central line, patient is on Foley's catheter, patient is on some implant already in place in her body. And about blood reservation, cross matching need to be done priorly, blood reservation has to be done. So this all history, this all handover need to be given by the assigned staff to the OT nurse. So this can be prevented further sentinel events. So I would like to just go further. So this is all we have done. So try and understand pre-operative phase workup we have done properly for better safe experience in intraoperative phase. So the intraoperative phase will begin as soon as patient is being wheeled to a OT. From the OT, patient is being operated and being shifted to the post-operative. This phase consists of intraoperative phase. So the most I would like to emphasize on this intraoperative phase, lot of sentinel event happened in future, like in previously in experience. So these all experience can be a better understanding for the prevent sentinel events. So I wanted to understand, like I wanted to make you all understand the IPSG goal number 4, surgical safety checklist. So this, as per WHO, surgical safety checklist consists of 3 components. One is sign in, time out, and sign out. So sign in is nothing but this surgical safety checklist will be announced in the OT when patient is being shifted to a OT table. The circulatory nurse will read up loudly, including with the all team members, surgical team members. Surgical team members comprises surgical and a surgeon, as well as assistant surgeon, anesthetist, as well as technician, scrub nurse, circulatory nurse, and other team members. So this in front of all the members witnessing the patient, sign-in will be done by the circulatory nurse. Sign-in is supposed to be done before induction of anesthesia. So this to avoid further complications, before induction of anesthesia, the circulatory nurse will announce is the right patient has been taken onto the table. So she will announce loudly the patient name as well as the UHID number. And once patient is confirmed, yes, my name is so and so, then that will be declared by all these OT members. The second thing is, OT equipments, whatever OT equipments is all function on patients or not. So she will be confirming once again the OT equipments in the operation theater is all function properly. She will be confirming with the OT team members. And the third parameter, which I would like to emphasize, risk evaluation by the anesthetist for the patient. The anesthetist will be, risk evaluation will be done for the patient. Is there any like anticipation of blood loss and any preservation of blood products? So this will be done by the anesthetist and the surgeon, correlation with the circulatory nurse. And the timeout will start before surgical incision will start. So again, once again, they'll be announcing, they'll be declaring about the patient name and confirming it once again. Is the surgeon, is the anesthesia, and is the surgeon is anticipating the further complications on the patient. They'll be coming and rule outing, and they'll be declaring about the patient's condition. Yes, all will be coming onto a pace, and they will declare the patient's condition as well as the equipments. And one more thing will come, count, sponge count as well as the needle count, and the further whatever being used instruments count. So this is all in front of the witness of the surgeon and anesthetist, and the surgical team members will be declared how much ever, whatever count being using for the patients for surgery. So this is about timeout. And coming to a last component is sign out. Sign out is nothing but before closure of skin, we ensure anything, whatever we have used instruments and the sponges, as well as the gauze, as well as the needles, this all been taken out, and we should get tally of previous count and as well as before skin closure count. So this is very important. In this phase, so many sentinel events happen. So we heard many times patient has been patient abdomen is being closed with some artery forceps. Patient's abdomen is closed with some gauze space. So further will be complicated for the patient, and re-exploration, a lot of complications can happen. So this is very important. I would like to emphasize every OT before starting procedure, we have to follow this surgical safety checklist to avoid further complications. The next last phase is very important, post-operative phase. Now everything like during operation, everything went into a normal. Now the surgical team members, including anesthetist as well as the surgeon and the nursing team and the technician, other team members, will have the understanding how effectively patient can be shifted from the intraoperative to post-operative care unit. So they will understand, they will try to judge, like, they will try to understand how effectively patient can be shifted to a ward setup or the critical care unit. So during intraoperative, they will analyze patient can be shifted to a OT or patient can be shifted to a surgical care unit or ICU care unit. So they will understand, and they will put, they'll try to work up during intraoperative phase, and patient can be smoothly shifted to a post-operative phase, that is immediate recovery care unit. After that, patient can be shifted if it is patient is very minor surgery and patient is critically stable, can be shifted to a ward. Patient is critical and patient needs some intensive care monitoring, can be shifted to a AMC or surgical ICU setup. So before we shift post-operative room readiness, we have to check as a nurse, when we are receiving any OT patients, we should ensure essential equipments need to be assembled nearby, as well as the functionality of the equipments can be put up for the patient's safety. So the room readiness can be taken. So as a nurse, we have important role in post-operative nursing care. So the important thing is every patient who undergone the surgery, patient will have the experience of pain. So we should understand the pain is a fifth vital parameter. We have to consider the pain also need to be treated whenever it is necessary. So this pain management need to be taken very important role. And the second thing is the wound care. It is very important. As per the IPSG fifth goal, we have hand hygiene, and to prevent hospital-acquired infections, the wound care need to be taken in an aseptic manner. So if we take properly this wound care, we can prevent SSI, surgical site infections, and further complications. And management of drains. So most of the time, what happens when patient is being wheeled to a ward setup or the surgical care unit setup or AMCU critical care unit setup. So we have to ensure what all drains patient is having, whether it is in intact situation and patient drains are need to be protected, our responsibility, as well as the nutrition. Patient need to be hydrated because as patient is on NBM, so patient is NBM till that, as well as the post-operative continuously, we have to understand the nutrition important role. Fluid balance and IV fluids therapy, we have to always understand because patient is on NBM, fluid therapy, hydration therapy need to be continued as per the doctor's order. And in this output, intake and output chart also is very important because most of the time we have to avoid this complications, sentinel events. We can pick up few things with the intake and output of the patient is having. So we can tell intake and output whatever upgradation to the consultant and to the surgeon. Elimination needs is very important. So these are the few enlisted post-operative nursing care can be watch very carefully, as well as we can pick up very complications and we can notify to the surgeon as well as the concerned doctors. So I would like to emphasize the last component before closing for the topic. So this 3 phases, when we take care very carefully as a nurse, we can avoid a lot of sentinel events. We can have better experience to the patient and we can enlighten a patient experience also. So I would like to just quote one theme as global surgical safety, safe surgery and save lives can be happen. It's in your hand as nurses. We have to protect our patient and the surgical team members, as well as the finally the quality of care as well as the burden of the patient can be reduced. So next I would like to ask a few questions. So we have ended up the session. I'll put the one question saying that, okay, when we are not taking care, okay, when 72 years, you can see a question, 72 years old woman who is scheduled for hip replacement is taking several medications on a regular basis. But which drug category might create a surgical risk for the patient? Most of the time, we all experience, sometimes we have faced also. So which is the answer? So we have in front of you, the options are there. So you can put the answer. Okay, the answer also has been displayed. So most of the time, anticoagulant drugs therapy would increase the risk for hemorrhage during surgery. So please understand all the nurses. So this is one of the important role we can, prevent, and we can have smooth functioning for the patient. The next question, the nurses assess a client's surgical incision for signs of infection, which finding by the nurse would be interpreted as a normal finding as a surgical site. So this is also one of the important important thing. Sometimes we tend to skip. Sometimes we try to pick up this sign earlier so that we can save the patient. So this is the options also given in front of you. The serious drainage is an expected finding at a surgical site. The other options indicates signs of wound infection. Wound infection usually appears 3 to 6 days after surgery. So as IPSG goal number 5, we say to prevent hospital acquired infection, the important role is hand hygiene as well as the OT traffic control during intraoperative phase, and how effectively we are following a sterility during intraoperative phase as well as the post-operative phase. So I would like to thank entire team and for bearing me. Thank you so much. Over to you, Pratyusha.
Prashant sir, we welcome you onto the panel, sir. So let us discuss the most important challenging areas which you always see that we skip some of the areas and that might affect the patient services. Uh, Talking about the pre-op area, so that is a phase 1. So what is the most important and challenging area that the nurses needs to insist more on the patient safety?
Yeah, Pratyusha, good afternoon. So when the patient comes to the pre-op area, either from the ward or from ER or from the OP, the first thing, the most important things the sister should check, the nurse should check is the consent. Though the consents should be taken by the surgeons and anesthesiologists, their role is just checking whether it is done or not. Okay, so it is the nurse has to, before shifting the patient, wheeling in the patient to the operation theater, it is mandatory for the nurse, whoever is shifting the patient to the OT, she has to check whether the consent was taken or not and what kind of consent it is. And other important thing is check the preoperative orders which were given by the surgeon, as well as check the pre-anesthetic form and what are the orders given by the anesthesiologist as well. Most of the times what happens is they just check the preoperative orders given by the surgeon, which is written in the case sheet. But the anesthesia, the pre-anesthetic check is done in a separate form and the orders are written in a separate form. So they should make it a habit to check the form as well. And what are all the orders written by the anesthesiologist should also be taken care of. They have to check whether all those things are, they have to tick the checklist whether all those things are done, whichever are ordered by the anesthesiologist also. And if there is any discrepancy between the surgical orders and anesthetic orders, they should, talk to one of the team members and decide what has to be done. So that is the most important thing, apart from other things like whether they have done all the investigations, whether the blood is reserved, whether the investigations, all the radiology and other investigations are there ready with the patient. And these investigations, especially in an orthopedic surgery or a vascular surgery, wherein you have to see the CT angiogram and all that, having the films is mandatory. Not only the report, say if it is a CT scan, not only the report, having the films is mandatory because we depend on the films rather than the report which was given by the radiologist.
Sure. Yes.
So these things are mandatory in the pre-op area.
In case if we wanted to elaborate the discussion on the pre-op areas, now the handoff has been given. And as you said, the investigations and the reports which have been done with the patient, how stable hemodynamically the patient is, all this has been done. And now the patient is on the operative table. So what plays a major important role as a team, not as a nurse, but as a team, as an anesthesiologist, like you might have evidented so many surgeries. So how important is the surgical safety checklist, sir, in the operation theater?
Surgical safety checklist is the most, I would say, the highest priority has to be given to surgical safety checklist. This was introduced by WHO some 15-20 years back, and now it is mandatory to do a surgical safety checklist inside the OT. Okay, so the most important thing would be to ask the patient what his name is. Most of the times, what happens is in the initial days, now we ask the patient, every patient, what his name is, which doctor is attending him, because the patient's name may be same. Like there are the 3-4 Srinivas on the list every day. So we have to know which Srinivas is this and who is the surgeon of this Srinivas. So we ask the surgeon's name also to the patient. We ask this to the patient. We put these questions, ask him what surgery is undergoing, which surgeon is operating on him, and which side is undergoing the surgery. These we confirm with the patient, then confirm in the case sheet also what in surgeon's orders, what he has written, what his notes is, and which side he wants. Sometimes a patient who has osteoarthritis in both the knees. Okay, so they decide to get the right knee first. Though the symptoms are there on both the sides, we have to confirm what the surgeon also, what is the surgeon's thinking, whether he wants to operate right or left, what he has communicated to the patient. If there is any discrepancy between patient and surgeon, we have to again discuss with both the parties, the surgeon and the patient, and then come to a conclusion which part they want to do. So it is mandatory to talk to the patient before in the sign-in process itself. Meaning signing in, the first questions should be to the patient, to give his identity, to which surgeon is operating on him, what is the part he is getting operated, what is the surgery he is getting on. Then comes the other things. Then asking the anesthetist whether the machine is ready, whether patient is stable, what is the anticipated blood loss, allergies, and all these things. Allergies are also to be asked to the patient only. So we note down in our anesthetic form, we again question the patient what his allergy, if he has any allergies. And one more important thing to the anesthetist, not to the nurse, though we check the airway of the patient, we check the airway to to assess the difficulty or ease of intubation of the patient. So it is mandatory for the attending anesthesiologist, whoever is there. Pre-anesthesia checkup may be done by somebody else. But if I am anesthetizing that patient, it is my duty to check his airway again on the operating table. So we made it mandatory that everybody, whoever is anesthetizing, will check the airway of the patient on the table also before inducing the patient. So apart from this, the surgeons, we discuss with the surgeons what his plans are, what difficulties he's going to face, and how much blood loss. All that would be dealt with us. But most important thing is identifying the patient, identifying the surgery, and identifying the site of the surgery. These are most important things.
Wonderful, sir. Actually, the team briefing is really important to to avoid the chaos whenever during the intraoperative phase.
Yeah.
Especially speaking about this sample collection, sir, whenever we wanted to send some kind of pathological samples, that we take a tissue or a biopsy. So how important is that? In so many times we feel challenging areas, like we will try to preserve it somewhere and the nurse or somebody else will try to discard it accidentally.
Yeah.
So how important is the preserving this specimens during the intraoperative phase?
Yeah, there is a thing for in the timeout, in the sign out thing, whichever is there in this checklist. There is emphasis on identifying the sample, what has to be done with the sample. All these things are also there. The surgeon has to clearly state what samples have to be sent and where it has to be stored, whether it's saline or formalin, and which lab it has to be sent. Sometimes you have to send to pathology and it lands up in biochemistry lab.
Yeah.
So all those things have to be, and the form has to be clearly written by the surgical team. Surgical team member has to clearly fill the form and check the labeling with the container. Check the IP numbers and IDs with the in the form and as well as the containers, and make sure that it goes to the lab. It is the duty of everybody to check things whether they are done or not. Both surgical and nursing, both have to make sure it goes to the lab.
Sir, in case if the patient has got into different kinds of anesthesia, we always tell, like regional anesthesia, spinal anesthesias, all this. So how to take care of a patient in the post-anesthetic care units? What is the prime important that initially once the nurse receives the patient from into the post-anesthetic care unit, what important things that she needs to monitor?
Any patient coming to the post-anesthesia care unit, the things are like any other patient care. Like you have to check the early warning scores and inform the concerned physician. And the physician here is anesthesiologist. Okay, so they have to check whether there is tachycardia, whether there is hypotension. All these things have to be checked. And a patient who has undergone regional anesthesia, like spinal or epidural, the patient is nursed in a more or less flat bed. That is, you don't keep too much of head-up position because the chances of hypotension is more in these patients. So if the pressures are okay, you can make a slight head-up tilt. But then more or less flat position is advisable for these patients. And any patient who has, except the neurosurgery patients, any other patients who have borderline blood pressures, they have to be nursed in a flat position, immediate post-operative. Later, once the things stabilize, you can make the head up. And always there has to be proper handing over between how many fluids were given intraoperatively and what is the plan post-operatively, how much fluids have to be. In some cases, we restrict fluids. In some patients, we give over fluids. So all these have to be properly given handover, and they have to see the post-operative orders, both in surgeons and anesthesiologists notes also. And then if there is any discrepancy, again, they have to discuss with the concerned parties and decide how to be given. And one more, utmost care should be given, utmost respect to be given to patient's pain. No patient should complain of pain in a post-anesthesia care unit. At least in post-anesthesia care unit, no patient should complain of pain. So if somebody is complaining of pain, immediately report to the concerned anesthesiologist, and patient's pain has to be taken care of, because pain has got so many other effects. Like pain causes tachycardia, which can confuse you whether it is hypotension or pain. Okay, and pain causes it can cause hypoxia. Pain can cause lung atelectasis. Pain can cause distress to the patient. Pain can cause post-traumatic stress disorder. So all these things can be avoided if you take care of pain properly. So the role of nurse here is, whatever are there in the orders, you can try those things. If still the patient is complaining of pain, don't neglect the patient telling they have given just paracetamol right just 5 minutes back or Tramadol 10 minutes back. Don't do that. Just give adequate time. 5-10 minutes you wait, then again inform the anesthesiologist, and the pain has to be taken care of. Pain is the most important thing which has to be taken care of post-operative.
Can you just elaborate us on epidurals? Epidurals as a patient, as we are speaking more about the pain, so epidurals comes and does the major part when we are trying to talk about the surgical patients.
Yeah. So epidurals, we actually start the infusions intraoperatively itself. Before shifting the patient itself, we give a bolus dose, then get the patient out. We load the drug there itself immediately after the patient is shifted, and we run it through a syringe pump most of the times. So the mishaps which can happen here are connecting a epidural drug to the IV. This is the most common mishap which happens.
Yes.
So care has to be taken. What is going there? Okay. So any drug which comes with cane, ropivacaine, bupivacaine, lignocaine, all these canes have to be attached to the epidural catheter if it is there, or a nerve block catheter it is there. So the mode of the drug delivery has to be taken care of. You cannot give them in IV lines, because these are dangerous drugs. They can cause cardiac arrhythmias. So it has to be taken care of. And even with the epidural infusions, patients sometimes complain pain because there is something called tachyphylaxis, wherein the patients get used to the amount of drug which is receiving. So that does not work for his pain. So you have to inform the anesthesiologist again, so that they give an additional bolus dose and then continue the infusion. So even on epidurals, patients can have pain, and this pain has to be reported.
So what about this patient-controlled analgesia we always speak? Do we practice this, sir?
Yeah, we practice this, but we have IV patient-controlled analgesia. Patient-controlled epidural analgesia also is there. PCEA is also there. It is now being commonly used. The thing here is there is a lockout interval, and we set how much, whenever the patient has pain, he himself is given a switch wherein he presses it and he can deliver certain amount of drug. We set how much amount of drug has to be given, delivered with each flick. So that much amount of drug will go into the epidural catheter or IV catheter, whatever is the mode. Then we also put a lock-in interval. Now the patient cannot keep on clicking and getting the drug, because some patients will become opioid dependent and they they continue to click. So we avoid that, so that there is no overdose. We keep a lock-in interval. Like for example, we can keep a lock-in interval for Federal for say 15 minutes. So you can press once in 15 minutes. You cannot press twice in 15 minutes. Yes. So that is how we set it. It is now a common thing. So it is being practiced everywhere. So it makes your life easier if it is.
Yes, sir.
The patient will take care of his pain by himself. Only thing is you have to just adjust the doses and leave it.
As a final note, as we are speaking about avoiding the surgical disaster, as a pre, intra, and post, we spoke a lot about it. So what is your final take-home message you wanted to give for the nurses?
No, we missed a couple of intraoperative issues. We talked preoperative and postoperative, but there are a couple of most important intraoperative issues which are very important, like checking the sterility of the instruments which you have opened. Okay.
True.
Pack has to be sterile. So we keep certain indicators, both outside the pack and inside the pack.
Yeah.
It is the duty of the scrub nurse to check whether first the circulating nurse has to check the outside pack, and the scrub nurse has to check once she has opened the pack, she has to check the inside indicator also. Both have to be sterile. Then only the pack is sterile.
Yes.
There is a discrepancy because there is it indicates which color is which color means sterile.
Change in the colors,
so
all these indicators.
That has to be checked religiously, and it is a good practice if the surgeon also checks by himself whether it is sterile. Both the indicators have to be checked. That is mandatory. That is one thing. This is the most important thing which has shown to decrease the surgical infections.
Yeah.
And other thing is gauze count, mark count, instrument count, needle count. These are most important things, and they have to be done properly. It cannot be clumsy. We have separate stands for hanging the gauzes, mops, and all that, and they have to be done in that way only. Even it has to be practiced both in minor surgeries, majors, whatever kind of surgeries. They have to religiously practice that so that they don't miss any of these issues. And the counting at the end of surgery, before closure of the surgical site, before closure of abdomen, whatever, or thorax, the count has to be loudly declared. How many mops are used? They have to count loudly and declare, yes, we have used 5 mops in this case, and 5 are out here. And we have used 10 gauzes and 10 are out here. It has to be loud and clear so that nobody misses anything. And so also the instrument count and needle count also, because this prevent a lot of mishaps. So yeah, once you follow all the points once you see and follow religiously all the points in the surgical safety checklist, so many things can be prevented.
Thank you, sir. It was a wonderful discussion that we have gone into each and every area of this perioperative phases. And Chandni also have elaborated us most upon what is each phase consists of, and she has made more discussion on into a crisp one. And the discussion which you have made is like the challenging areas, mostly the nurses, where they will go wrong and where we need to put a focus, and where the red flags will be raised during the pain management or when the patient is being received from the post-operative areas and all. So thank you so much for such a wonderful session, sir. Thank you, Chandni. It was a really wonderful talk that you have given in a very crisp way. Thank you, sir. Dr. Prashant Reddy, sir, like you were wonderful in your talk, and it was a very cool and calm way we have concisely done this webinar. And for the next webinars, we will also look up in the most interesting topics for the next coming up webinars for the next Thursday every 3 p.m. every day.